begin with our topic today. When we have an endoleak, first we need to have an aortic aneurysm. So first, what is an aortic aneurysm? This is a focal dilatation greater than the 50% and the normal diameter of the adjacent healthy aorta. This means that it's more than 3 centimeters. And if we have more than 5 to 6 centimeters, there's a chance of rupture between 3 to 50%. We have two types of endoleak, the one that appears within 30 days, and the second and secondary endoleaks appear after 30 days, and we need to have at least one previous negative imaging study. In the epidemiology, there is a prevalence between 4 to 8% in screening studies. It's more frequent in male over 60 years, but there's also some risk factor like obesity, smoking, hypertension, dyslipidemia. And the diagnosis is based on the clinical suspicion and with imaging studies, such as ultrasound, MRI, or CT. We have two types of treatment, the open repair. This is left to specific cases because it's more invasive and needs more time of recovery. And then the endovascular repair, this is less invasive, but requires more imaging surveillance during the life of the patient, and is also more expensive. For example, here in Ecuador, we don't have many persons or doctors that make this procedure, so it's really, really expensive. So the endovascular procedure uses a covered stent graft to serve as a blood flow conduit through the aneurysm sac. The graft is anchored to the proximal and distal ends to the non-aneurysmal portions of the artery. We have diversity of materials, and this depends on the quality, the thickness, and the geometry of the struts. So we have stainless steel, alloy, polyester, nitinol. We prefer nitinol because when we made imaging studies, we need to choose the best material so we don't have artifact. Here we have 3 imaging type of studies. In the middle, we have the annex and chest X-ray. Let me show this. Okay, so here we have the stent, and we can see it clearly, but when we go to a CT scan, there's a lot of hyperdense artifact, and we cannot make sure if there is an endoleak here. And with MRI, it's almost impossible to even notice how is the anatomy here, unless where is the graft. So the endoleak is when the blood flow outside the stent but inside the aneurysm sac. It occurs in at least 1/4 of the patients, and some of the risks are the number of branch vessels and the amount of thrombus inside the aneurysm sac. Kleber and his team classified it in 5 types, so we're going to make a small review of this one. The more common is type 2. So with these diagrams, we're gonna see or understand more easily how they are. So type 1, we have an endoleak proximal, distal, or in the iliac occluder. If there is a migration more than 5 millimeters, we can consider here that the graft move and we have an endoleak. So in type 1, we see here the aorta, the aneurysm, and the graft. And if we can see in these coronal and axial reconstructions, we can see this hyperdense artifact. This is the endoleak. There is blood going outside the graft, but is inside the aneurysm sac. Type B is distal. So again, we have the aorta, the aneurysm, the graft is here, and distal to the graft, we have another aneurysm, and these small hyperdense areas are the endoleaks. And finally, the one type C, the iliac occluder, happens when we have an aneurysm and we need to make a bypass femoral. So we go with the blood from this iliac, we make a bypass to another iliac artery, and we close this proximal portion of the iliac artery. So we have one type C endoleak when there is a leak here. Type 2, as I told you, is the most common. So here we have a retrograde blood flow from lumbar arteries, mesenteric arteries to the aneurysm sac. So for example, we can see here is our aorta. Here we have the superior mesenteric, the intestine, and with the inferior mesenteric artery, we have a retrograde blood flow. And here we have blood at the aneurysm sac. We can see in this bigger CT scan, our aneurysm sac, our stent. Here are the lumbar arteries, and we have blood flow inside. So this is an endoleak type 2. Type 3 is really is rare, and this is a discard diagnosis, because when we have a type 3 endoleak, we are talking that there is a structural failure, like holes or fractures in the fabric of the device. This can happen because we have repetitive pulsative stress from the arterial flow. So basically, we have to discard the other types of endoleak before we can say this is a type 3. So there are two types. One, if we have tears in the fabric of the device, or when we have more than one graft, there can be a junctional leak. So as I told you, we need to see the aneurysm sac, blood inside the aneurysm sac, but outside the graft, as in this case. Type 4 is more specific for the patient. It happens in the post-implantation in the immediate period, and this depends on the anticoagulation level of the patient. So we just correct the anticoagulation level, and this endoleak corrects. So there is no any structural failure, there are no other vessels, there is no move of the graft. It's only that the blood is less viscous than usual, so the blood goes outside the graft. And finally, type 5 is also called endotension. This means that the aneurysm gets bigger, but there is no specific cause. There is not an endoleak. In this diagram, we can see it more clearly. So for example, in the first year, the aneurysm had 6 centimeters of transverse diameter. 2 years follow, the aneurysm grow, but there is no endoleak, there is no another bleeding. So this is called endotension, and it's believed that can be because there are existing endoleaks, type 1, 2, or 3, that we didn't make the diagnosis. Here is a resume. Type 1, proximal, distal, or iliac occluder. Type 2, from the lumbar and mesenteric arteries. Type 3, when we have structural failures like holes. And type 5, when we have endotension. So what image studies do we need? First, the chest X-ray is like the basic study. We need posterior, anterior, and a lateral radiographs. So we can see where is the stent. And also in the oblique projections, we can see if the wires have been broken. This is very important to evaluate with the person that made the EVAR procedure, because they know exactly where the stent is. So because sometimes the radiologist only see, but it has not exactly idea where the graft was positioned. Second, the ultrasound is a very good option. It's cheap. We have disponibility a lot in any hospital or clinic, but we have some problems. It depends first of the operator, second of the patient. For example, if there is obesity, increase of bowel gas, this can interfere in our scanning. Also, there are studies that say that we have a high sensitivity when we use contrast, but this is really expensive. We need personnel that knows how to use the contrast. And also in some places, there is no availability of the contrast. For example, in this image, we don't use contrast, but as endoleak is big, we can notice it. So here's the aneurysm sac. This hyperechogenic line is the graft. When we apply Doppler, we can see this leak here. So we can assure that here is an endoleak, and the patient goes to another next imaging study to know what type of endoleak is it. The CT scan is our most favorite, as a way to say it, imaging study, because we have a good anatomy definition, there is less artifact, and we use contrast. So it's really, really important that we use 3 phases: simple, arterial, and a delayed phase. The simple can help me to guide if there are calcifications, not to get confused with an endoleak. The arterial is good for big endoleaks, and the delayed phase is very useful when we have very small endoleaks, so we need more time with the contrast before we can see the endoleak. Here in this example, we have a sagittal reconstruction, the aorta, the graft. Here is really, really big, the aneurysm sac, and we can see this hyperdense artifact here is the blood that is going outside the graft. The MRI is a good study. It is said that it can help in very, very small endoleaks, but it's more expensive. There is a lot of artifact, and more if we have, for example, a stainless steel graft. And sometimes we need more prepared professionals to read or interpret this kind of study. So we need a contrast, gadolinium, and it's really good with a small endoleaks, as I told you. So for example, here in the upper image, we have T1 without a contrast, and here we have T1 with contrast. So here we can see the small leak, and we need to make all the reconstructions to know what type of endoleak this is. Nuclear medicine is not frequently used. We tag red blood cells and we make the scan, but there is not good anatomy, it's less sensitive, also it's expensive, we need more time. So it's not a study that we recommend to use. And finally, the angiography is probably the favorite image study of the person that make the EVAR, because we can see in real time and with high spatial resolution where is the endoleak, how is the direction of the endoleak, and the amount of blood that is in this leak. So we have this angiography, this obstruction, and we can see here the leak. Finally, I want to share with you a case. It's not an abdominal aneurysm, but it was really interesting. So we have a male patient, 55 years old. He had high blood pressure for the 30 years past and has chronic kidney failure. In these 2 upper images, we have a dissection of the ascending aorta. The patient went to an open repair. That didn't went well. So here we can see there is a little bit of edema in the sternum. This is because he went to a surgery. It didn't work. We continue with the dissection with aneurysm, so they decide to go with an EVAR procedure. In this angiograph image, we can see here the graph where it's positioned and the final position of the graph. He went to follow up 1 year. It was almost fine. The thoracic aorta grew a little bit, but no big deal. 15 months after, the patient returned because he said that he felt a mass at the sternal level, and it was almost 9 centimeters. So it was a really big mass. Here we have the first image. Here is our graph. That was an hematoma that was formed with the first procedure. And here is the big mass that we have. So this is the sternum. The staples of the sternum get open. And if we can see in this coronal reconstruction is also the stent graft, the hematoma, and with this bigger image, we can see here a small hyperdense artifact outside the graft. And even here is a hole. So maybe image can trick us. So we need to scroll up and down the image to make sure this is a real hole. And in this case, it was. So after 15 months of the graft, the patient had an endoleak with a pseudoaneurysm that opened the sternum. Here we have the big aneurysm. So the patient felt a pulsative mass in his chest. This was a type 3 endoleak. There was a structural failure of the graft, and was a really interesting case because, as I told you, this is more rare. And with a pseudoaneurysm, is also more rare. So this is the case I want to present you. Endoleaks sometimes it's like difficult to understand, but we just need to go to the classification to organize our mind how we need to search. And that's all. I want to say thank you to the people that helped me with this presentation and with my hospital and my university. I hope you enjoy this, and if you have any question, you're welcome.
Thank you very much, Dr. Fernando Avalos, for your wonderful presentation. Please, we want to know if there is anybody that have question pertaining to Dr. Fernanda's presentation. We'll give you some minutes to ask your question.
Any question?
Okay, in the absence of